We're going live.
We're going live in just a moment.
You want that recording to be on? We don't need to have it. You're fine.
Okay, thank you so much, Dr. Levine, for joining us today. I know just how busy you are. I want to thank the Chair of Health and Welfare for helping us to gather questions from the senators that we were able to get to Dr. Levine beforehand. That doesn't mean we can't take other additional questions if time permits, but I thought I would turn over to Dr. Levine immediately so we can get as much time with the doctor as we can. Thank you so much for joining us, Commissioner. Really appreciate it.
Thank you. I guess for formality, I'll introduce myself again. Mark Levine, Commissioner of Health. I get the sense it would be best to go directly to the questions without any major opening statements or anything of that sort. Is that fine?
That would be wonderful, because I think what we all need is the most up-to-date information that we can get. Thank you.
Okay, and I'll take the liberty of reading the question and then answering it. Question 1. People are at home with care delivered by private caregivers, not home health services. This might include people with disabilities as well as those with conditions requiring home-based services. Is it possible, perhaps through primary care doctors, for these people to receive the vaccine regardless of age requirements? How might they make arrangements for their shots? So, we were pretty strict in the definition initially on this one. And the bottom line is those who deliver home health services are in a healthcare related capacity. So they're delivering health services. That's different than a person who's requiring care because they cannot be as independent in their activities of daily living or what have you, and require assistance with them. Often those are provided by family members, sometimes by private contracting. So the goal here was, again, the population of people who are healthcare related, if you will. The CDC does not regard people with disabilities as having a definitively higher risk for a more severe outcome with COVID than someone else, although they sort of, if I could read directly from them, they say, disability alone does not put you at higher risk for getting the virus. You may be at higher risk because of where you live, like in a long-term care home. You may be at risk because you need to have close contact with care providers. You may also be at risk because you have trouble wearing a mask or complying with the other public health guidance, or you're more likely to have health conditions that put you at a higher risk to get ill from COVID. So we've been going with that, but I have to say that we are probably by the end of today, we'll have made a decision if other intellectual or developmental disabilities should be listed in the list of high-risk conditions. Currently, the only one that's listed is Down syndrome, most likely because that's the most frequent one and easily diagnosable and has data behind it. Many of the others, such as other chromosomal abnormalities, just don't have the data behind them because of numbers. But we're being more open-minded, and more to come on that when we have a final decision. With regard to can they get their vaccine through primary care, sort of regardless of their age, I'll try to just say it once during this presentation, we are very much adhering strictly to the age banding that you've all heard about countless times. The reality is our goal is preservation of life, and there is some good data, which I may have a chance to show you, that we're already accomplishing that. There's also good news, however, on the allocation front, as you've been getting little by little, both from the governor and from the president. That may be a game changer at some point in terms of allowing many others to get vaccinated far earlier than they thought. Question 2. What types of outreach and accommodations are taking place for individuals with disabilities, for those without English language proficiency, for those in high-risk groups such as BIPOC? So clearly, we've made the news a few times. I'd like to think mostly in a positive way, but not 100%, with regard to our reaching out to the ELL community as a high priority community. We've been able to actually work with that community in a very productive way through provision of interpretation, education, and communication resources, and for actually vaccine access resources, getting them to the vaccine or the vaccine to them. We have, across the ELL and BIPOC group, made the commitment that if there was somebody in an elderly age bracket that qualified for the vaccine and that individual lived in a multi-generational housing, that was a significantly strong risk factor for that population. And we would not just take that investment of resources that I just recited to you and make it repetitive for every member of the family, but we would do it all at once, in a far more efficient and economical way, and make sense from a public health standpoint regarding the elevation and risk of that population. So I think we've done a great job in that, and we will continue as we go through the age banding to follow suit on that. The BIPOC and ELL populations are both age skewed in a younger set in our state. So the chances of actually finding such families are lessened as we go along, as we started, I should say, with the 75 and older. They're going to be much more common as we get into a lower age band. So that's my first 2 questions. Shall I just keep proceeding on, and then if people have other questions about my answers, we can do that at the end?
Yes, Dr. Levine, thank you.
Okay. Is there a plan to prioritize teachers if schools are fully open by the state or Washington, D.C., and the kids are back in person? Should there be? Well, first of all, our kids are back in person way more than any other state, I would dare say. There have been some statistics thrown around that somewhere around 85% of major school systems in the country actually have not opened up or been in person. And we, as you know, have been in person to whatever degree we have in each school since the very beginning. The decision about prioritizing anybody, whether they're teachers, whether they're another type of frontline worker, whether they work in a congregate setting, etc., has really not been made yet. It's going to be made after we finish the current phases, going down to age 65 and going through the high-risk health conditions. We're going to really be looking at the lay of the land at that time, the issues that are presented by various groups of frontline workers, the allocation of vaccine, the opportunity to get a large population vaccinated quickly, and make those decisions. So I'm being completely transparent that there has not been a decision made on that at this point in time, though there are certainly many in the communities that advocate for advancing various groups of frontline workers to the front of the line as quickly as possible. The CDC, as you know, just came out with renewed guidance regarding opening schools. That guidance is actually almost not pertainable to Vermont, since we're already operating in an open environment, whereas they are important for many other places around the country where the schools have not yet been opened. The punchline to their guidance, though, is that all the usual public health guidances that we do to keep ourselves safe in society apply to reopening of school, and they really look much more at the active cases in a region and in the positivity rates of the tests in a region to help those make those decisions. At the very end, they essentially address vaccination, and the way they address it is to state pretty clearly, and I'll quote from them if I can. Now, the piece of paper I have is not in my grasp, but it essentially said, vaccination is not a necessary prerequisite to opening the schools, period. Though obviously that doesn't mean you shouldn't do it, but it's not necessary for a reopening of schools. Question 4. This one I'm going to act very defensive about because I don't believe it's framed well, and I understand some of these were framed by constituents. As more Vermonters are vaccinated, a corresponding drop in cases and deaths is not, capitalized not, apparent. Other states take different approaches and vaccinate essential workers in addition to people by age category. These states appear to have better results. Is a different prioritization approach now warranted? Should Vermont provide doses for essential workers such as staff in schools, childcare providers, social service providers, and grocery store workers? If I may ask the Lieutenant Governor, am I able to share screen?
Dr. Levine, this is Senator Ballot here. The Lieutenant Governor is no longer in the chamber, but I will ask our staff, Vanessa Davison, if that is possible for us to do. She is making you a co-host now, Dr. Levine. So you should be able to share. Do you see it on your end?
Yes, thank you.
Thank you.
I just need to find what I want to share. Nothing happened probably, right?
We're not seeing anything yet. Oh, that's looking better.
Well, it is and it isn't. It's not what I had up originally. Bear with me for a second. Well, I won't waste our time. I think in going into the Zoom reading, I lost what I had up there, but.
So keep in mind, Commissioner, that after your presentation, you can send any information or slides that you want us to get to senators, and through the Pro Tem's office, we can make sure everybody gets that. So just let us know how we can support you in that.
Sounds good. What I was going to show you was some slides from our presentation yesterday at the press conference, which reveal actually a dramatic drop in cases and deaths in our long-term care facilities, as well as in our general population in the age-banded groups that have already gone, which is, of course, age 75 and older. So I would submit that not only at this very brief interval of having been vaccinating people, we are seeing just the kind of drops in cases and deaths. And we're now at levels of 4 outbreaks in long-term care facilities of very small numbers of people. The numbers of deaths have dramatically decreased. And I don't think that would make us say we made a mistake and that would warrant a new approach, as the question was implying. Now, the question also still asks, though, should Vermont provide doses for essential workers, which I believe I've answered in the previous question. I will say as an additional point that there are many states that did follow strictly by recommendations from the Advisory Committee on Immunization Practices. And when they opened up after the healthcare workers and the long-term care facilities, they essentially said, here are our priority groups. Everybody over 65, everyone with a high-risk condition, and these groups of frontline workers, and whatever groups they chose. What they essentially did, which is making them look at us with longing, is they opened up in Vermont, that would have been 300,000 people at one time, with 12,000 doses of vaccine coming into the week. So figure out the number of weeks it would have taken. The goal that you would have had would be to try to help all of those groups because they were priority groups. But the result would have been disappointment amongst every one of those groups. Because unless you were the member of one of those groups who got their vaccine in the first month, you would be waiting 5 to 6 months to get your vaccine. And that means that there'd be many people who are 80 plus years old who would have been replaced by younger people in the frontline workforce who weren't going to die anyways from COVID by statistics, and the 80-year-olds might still have. So we stand by that. Next question. Does the federal government's distribution plan shortchange Vermont? By tracking how many vaccines each state is getting per capita, is Vermont getting fewer doses because we're doing better than other states? So we are not being shortchanged. We are getting a population-based allocation. Keep in mind, we are the second smallest state by population, so that's where our 12,000 doses pale in comparison to many other places, but it is on a per capita basis. The previous administration had raised the issue of not helping states that were doing better, but penalizing states that weren't doing well with their vaccine and giving the doses to the states that were getting it into arms better. This administration hadn't said that till date, but more recently, we've heard a little murmurings of something to that effect, but nothing like that has been implemented at this point in time. So there's no penalty. To answer the question, which is really the opposite, there's no penalty in being a state that's doing it well now to our vaccine allocation. And in fact, we just looked at data today that shows that we're number 5 in the country when it comes to percent of the population that's gotten 2 doses of vaccine. And we remain in the top 10 for received and administered. Next question. In areas of the state where there is a higher prevalence of positive cases like Rutland and Bennington, why can't more vaccine doses be available than just doses based on population or age group? My answer to that is the same answer we've given when we talked to long-term care facilities about a month ago who had outbreaks. And they were really worried about all of their residents. It turns out vaccine is not an outbreak response strategy. In those long-term care facilities, many in the population would have already been incubating disease. They may have been asymptomatic, but they would have been susceptible to the disease and not helped by the vaccine. The same would go on a population-wide basis, knowing this virus does do a lot of asymptomatic transmission and asymptomatic infection. It's not considered a great strategy to go in and sort of act as a rescue agent when there's already a fire burning in an area. And one could submit that it would do more good to go to a place where the caseload was less and could eventually get higher, but get the population while they weren't susceptible so that they could then be protected when that caseload started to increase. I do want to elaborate on one further point on the essential worker question. If you haven't noticed, we don't use the term essential worker anymore. I try to use the word frontline worker when we're talking about special groups The essential worker category, when it's been looked at closely, can include up to 80 to 85% of the workforce. So it essentially becomes a meaningless term because no one's prioritized. Frontline workers, at least, is more like a patient-facing healthcare worker. In this case, it's a public-facing frontline worker who presumably would have more risk of getting disease because they're public-facing and more risk of transmitting disease because they're public-facing. So I prefer to look at it that way. Next question. Out-of-state visitors are bringing COVID into Vermont. 23% of cases in Bennington County are from out-of-staters. How can we limit this influx? Is there enforcement? Is there enforcement in ski areas and restaurants, etc.? So, in Bennington County, it turns out that there are many people in the adjoining counties of New York who use Southwest Vermont Medical Center for their health care, who use clinicians in Bennington, or who use Vermont as their work site. So we shouldn't jump too quickly about the assumptions about the 23% and who they are. Some of them admittedly are skiers and tourists, but I don't want to overcharacterize that entire group in that way. And admittedly, many of us may not want to limit that influx if they are actually working in our communities, if they are actually, some of them providing healthcare because they come over to work as healthcare providers. And many of them come to work at our work sites. Some of them come to recreate, obviously. So there is a lot of good compliance on the part of ski areas. I know that we see pictures in the media of the worst of the conditions where there's too many people in a line and they're all gathered together. But the reality is a lot of the ski areas are doing it right and they're trying to comply with all of the public health guidance for how to safely use their ski area. Unfortunately, we do agree there are probably people coming in from out of state who are asymptomatically transmitting the virus, who may be not obeying all of Vermont's rules about congregate gathering and things of that sort. I wouldn't say there's been a lot of enforcement in that as much as there's been a lot of education and trying to guide people in the right way. The work areas at some of the ski resorts and in some of the communities that are adjoining have noticed increased cases at times, which we would probably have to attribute to the influx of visitors in those areas, but it's very hard to do that because those people are there often for a day or 2 days, and we don't have any contact with them from a healthcare system point of view. All we see is what may be left behind, which is a case at a work site or a restaurant. The reality is, we have started more testing at several of the ski resorts, and we're gathering data from that now. It just started over the weekend. So we have offered at Bromley antigen testing, and I'm told about 200 people availed themselves of that, just straight from the parking lot, walking in. And as you know, antigen testing is something where you get the result pretty quickly. We've also at Stratton, where there was already a pre-existing clinic, tried to amp up the PCR testing available. And again, this is for the community, for the workers, and also for visitors. So we'll have some more data on that very soon. Three more questions. Actually, no, two more, because one of them repeats one about the number of doses of vaccine coming in. Recent data reveals that incarcerated individuals in Vermont have contracted COVID at a rate 11 times greater than the state's general population, one of the largest disparities in the country. I have a question about that. What data? I've never seen that data. However, I think I understand that data based on the question because it probably includes the entire population of our prison system housed in Mississippi. If we use that as what this question is including, then I'm sure it's astronomical because we had over 200 people housed in Mississippi, and we had 200 plus people who eventually tested positive there. So that would be an extraordinarily high rate. But if you look at what's gone on within the boundaries of our state's borders and the population that we still house here, I would say we have not had a very large number of inmates, probably a slightly larger number of staff who have tested positive, but it's clearly not 11 times greater than the state's general population if we leave out Mississippi. So that's why I'm interpreting this. The other part of the question is, could this be due to our success with the general population, or does it reveal vulnerability of inmates in a congregate setting? And is this disparity being addressed? And how can vaccines be sped up for these vulnerable folks? So the reality is, if you're in a congregate setting, whether it's a nursing home or a prison, you are more susceptible, just like a multi-generational housing, as I talked about earlier. So no question about that. There is vulnerability, but I would submit that the vulnerability is much more for our staff because they live in the communities they live in. And if there's more virus in those communities, they're going to be able to be susceptible to that, perhaps present at work feeling fine, and then a day later come down with symptoms, but have potentially infected people in their work environment. The reality is, it's not happening at an extraordinary rate in our prison system. Last question, can you provide a thumbnail timeline for when various age groups and other categories of people will be vaccinated? And when do we actually think we'll be able to congregate safely with or without masks? Well, that's a lot in one question. So, as of yesterday, 70 to 74. We anticipate probably just 2 weeks from then, we'll get to 65 to 69. And then maybe 3 weeks from then, because it's a little larger population, individuals with high-risk conditions, age 16 to 64. And that will bring us up to April, or early April. Now, of course, if vaccine allocation dramatically increases, as we're getting murmurings of from the federal government, that timeline can be accelerated. When do we think we'll be able to congregate safely without masks or with masks? Not next week. I've often talked about this parallel pathway of increasing numbers of people getting either natural immunity or vaccine-induced immunity, and the other pathway of continuing to do all the masking and distancing and everything we do now. That's going to go on through the spring into the summer. Will the early or midsummer be the time when we can abandon all of that stuff? Quite possibly, but I wouldn't want to be held to that. I'd much rather be held to saying during the fall, because that's more guaranteed, I would think. But summertime, quite possibly. You may have noticed that there's been a rather dramatic improvement in the caseloads of late around the country, but not just around the country, but even in the state of Vermont and in the region. And I think because of that, people are quite surprised that things have quickly turned around in ways that I would not have imagined that they could have happened, to be honest. Because the reality is, everybody didn't just suddenly realize, oh, there's a pandemic and I need to start wearing a mask and this and that and the other thing. They've really, it's not explainable by that, nor is it explainable by the vaccinations, because this trend began before then. So things are moving in a good direction faster than anyone in the country imagined. Now I believe I can share the screen now. How's that look?
Great, thank you.
All right, so this is our oldest population, whether they live or don't live in a nursing home. over 75. And look at the dramatic trend that occurred, beginning somewhere in the middle of January to now. 70% decrease in the cases in that age population. Keep in mind, vaccine began right around here and certainly could not have taken effect and explained all of this there because the community living 75-year-olds weren't even eligible at that point. Then if we look at weekly deaths, there's a rather dramatic decrease in deaths that have also been occurring. These are now weeks. These bars each represent a week. This is phenomenal. Some of this we should attribute to the good vaccine. Not all, but some of it for sure. And I think that, and this just gives you a glimpse at our counties. So the majority of Vermont counties are coming down nicely and sort of plateauing here. If you look at Bennington and Rutland, they've kind of leveled off and come down. Essex and Franklin are sort of still on the way up a little bit. They're outliers. Keep in mind with Essex, though, 11 cases in a week is a dramatic upturn in Essex because of, obviously, its smaller population. And that's the kind of numbers we're dealing with when we see this kind of data. Not so much with Franklin, which is a more populated county. So I'll stop sharing at that point and stop my recitation of the questions that were submitted.
Thank you, Commissioner. Can you just let us know how many more minutes can you share with us? Not to put you under any pressure, just want to know.
No, I think 15.
Okay, thank you. So I did have a senator ask me to ask you, thinking about what we should have asked you or could have asked you that we didn't ask you. What is information that we need to know that we didn't ask you about? Like that one?
Yeah, it's like choose your poison, right?
Yep. Well, think of it this way, Commissioner. We're really not trying to trip you up. We are your eyes and ears out in every single community in Vermont. And as much as we can get the most up-to-date, accurate information out to our constituents, it makes your life easier. That's how we're looking at it. So that was the reason for the question.
Yeah. So everyone, knows that the CDC just came out with their guidance regarding if you've been vaccinated and it's been within 90 days and you're 2 weeks beyond your second dose and you feel well and you get exposed to someone with COVID, do you have to quarantine? And the answer has been no. And we endorsed that. So that happened. Mm-hmm. Everyone else now is asking, so what about the quarantine travel policy? Mm-hmm. And, there were very few states, if not more than one, that has actually changed their quarantine travel policy at this time. And the CDC is probably not going to be our guide on this one because they deal more with international and not domestic travel. So I would like to see a nationwide consensus with a more national policy setting because travel, of course, crosses everybody's borders. But that isn't coming yet. So all I can say is Governor Scott foreshadowed a little bit yesterday in this press conference, as did I, and we'll have a little more to say on that on Friday, which I think is important and near to dear to everybody's hearts in terms of thinking about what the future holds. The other things that you could have asked, deal with a little bit what the last question asked, which is, how does vaccination change my world? And when are we going to get back to something closer to normal? So you just have to understand how complicated that is, because it didn't take us just overnight to get to where we are now. And in the governor's words, it was a turning of the spigot, in this way, closing of the spigot, little by little over periods of time. And now we're reopening the spigot very, very slowly as well. But we've gotten to a place where many states haven't gotten to, which is pretty much, lots of things are open and the public's health has been protected concurrently. The things that the future will hold, top of the list would be gathering with people again. Because as you know, one of the more recent restrictions that we added was no multi-household gathering. So you can expect us to be very assiduously following that data and looking at reasons to get us back into a more social circumstance, if you will, starting with trusted households, which as a concept came back way back in the spring, I think, last year. And then, moving towards larger group gatherings. Those are the things you would think would happen if enough of the population develops immunity, either through infection or through vaccination. And I just, feel we need to, this isn't the reason we do these things, but one of the positive side effects is we need to show people that getting vaccinated comes with benefits and incentivize and reward that. It is a sort of social contract kind of behavior in a sense, just like not, standing on top of a person and wearing a mask are both social contract kind of things. And vaccination should be viewed that way as well. But if people don't see their lives change over the ensuing months, why would they have done it in the first place? So I do think there's a connection there, and we have to constantly be conscious of that. And we have to be conscious of that with regard to our economy too. And suddenly having restaurants being able to have more than one family at a table, and people wanting to dine indoors, and then having greater capacity, et cetera, et cetera. You can name any sector you want, and the same follows suit. So those are the kinds of things that, I just need people to know we don't spend more than 12 hours not thinking about. We're thinking about it every day. We huddle every day. We meet about these things. And it's not just health. It's the governor. It's the governor's leadership team. It's all sectors of state government. So these things are very, very high on the priority list, but it's a matter of doing them in a very balanced and careful and data-driven way.
Thank you, Commissioner. So I have several senators who have sent me questions. I'm going to have them pose their questions so that I am not speaking in error. I have one from Senator Clarkson. I see that Senator McCormick and Senator Bray are also in the queue. Senator Clarkson.
Thank you, Dr. Levine. We all are so grateful. So this is terrific. Thanks for sharing your time. You touched about the private caregivers, and because you've already responded to me on this, and I'm just hoping that independent of the disabled community, what about private caregivers who are giving care to the elderly and the super ill, but who are private caregivers who are not part of a home health agency, but whose clients are getting vaccinated, but they aren't? And that's a key core group of people that I think we haven't addressed.
Yeah, no, I kind of hear you. And it came down to, there was just so many controversies about the 1A group and the healthcare workforce, and needs to limit that and make sure that people who were doing it were actually delivering healthcare. And, there may be some people, I hate to use the word, became a casualty of that. But at the same time, that's kind of how it played out. Just because there were so many levels of people who have contact with other people, but they weren't having the contact in the healthcare context as much. I know it's a parsing of words, and it's challenging, but we had to be as focused as we could, because there's literally thousands and thousands who feel they have the same right.
Yeah. So, Senator, I'm going to move on just because I think he has answered the question. Senator McCormick.
Thank you. Dr. Levine, first of all, I miss you. I enjoyed seeing you a lot last year before all this. It seems to me that the state correctly, I think, respects people's bodily autonomy and that we will not be compelling anyone to be vaccinated. But it also seems to me that someone who chooses not to be vaccinated has chosen then to continue to be a possible vector. And it is essentially a threat to other people's health. Has the administration given any thought to how the general population can protect itself from the unvaccinated?
Yeah, so just to get further into that concept, there's a term we're not using, but it's been called immunity passport. Another benefit of vaccination, if you carry a card with you, you get to do X, Y, Z, and that would include travel across borders and things of that sort. But even if not everybody gets vaccinated, we do suspect, based on these trends that we just saw in the pictures, that the amount of suppression of virus will be pretty good. And if we get the highest vulnerability groups vaccinated, most of whom do want the vaccine, because it's really, even though you didn't say it, I'll put words in your mouth, it's a younger population who will be more hesitant or more carefree about it. They are not the ones who are usually going to be the more vulnerable if they happen to get it. So as long as we're protecting our vulnerable, I think that's really important. And then we can afford to have some of those youngers who don't choose to take the vaccine. In addition, if we're fast enough, and I mean this very deadly seriously, with the vaccines across the country, we will beat out the variant strains that want to take over, that may or may not be as readily preventable with the current vaccines or require new vaccines on top of the old. So it really is a little bit of a race there as well. But then the other question that your question raises is transmissibility of virus. We still haven't been able to tell people with 100% certainty that even if they do get vaccinated, they can't transmit the virus to someone else. But based on this AstraZeneca data that came out a couple of weeks ago that's not yet been peer-reviewed, they found about 2/3 of the people that they vaccinated had negative nasal swabs continuously after their time of vaccine. So presumably had no virus that was viable to transmit to anybody. And that's what we think of most vaccines for respiratory viruses. They allow you to be free of serious disease yourself and not transmit any virus to anyone else. So in your scenario, the only people left who could transmit it to somebody would be somebody who wasn't vaccinated at all and had no natural immunity because they hadn't seen the virus before. And we hope that'll be a smaller and smaller number and that they won't be a big risk to anyone who could get sick, really sick, or hospitalized from getting the virus. That's the way I would like you to look at it. And the reality is, as you know, we're not going to wait to 85% of the population has been vaccinated before we tell everyone to take their masks off and start hugging people. We're going to do it far earlier than that. So it's just a matter of when in time that seems to be most reasonable. And it will certainly be reasonable after the highest vulnerability groups have been vaccinated, which would mean on my timeline, middle of April at the earliest, but that would be way early. So probably sometime late spring or summer. But we'll find out. It's all going to be, there's so many factors and variables in the equation.
Thank you, Commissioner. Senator Bray, it seems like he may have addressed your question already. Is that accurate?
Exactly. Thank you.
I believe Senator Hardy's next.
Yeah, thank you. And thank you, Commissioner. It's good to hear all this from the horse's mouth. It's very helpful as we're trying to respond to worried constituents. I just have a clarifying question on one thing that you mentioned about multi-generational households from BIPOC or ELL communities. And I'm not sure if I heard you correctly. If there's an older member in a multi-generational household, you of course want to get that person vaccinated. Are you also saying that you're vaccinating the whole household, like they're in a congregate living situation, or just the older household member?
The older household member is the index case, so to speak. So that's our pathway into the household if the rest of the household wanted to be vaccinated. And it's again in recognition of all of the intense resources that went into just that one individual and choosing to not have to replicate that every time somebody's age band comes up within the household.
Okay, thank you.
Commissioner Levine, could you take one or two more questions? I know we're coming up against time.
Yeah, we'll do it.
Okay, so last two questions, first Senator Lyons and then Senator Hooker. You're muted.
A quick question. I don't know how many immune deficient folks were included in the vaccine trials, and is it efficacious for immunodeficient autoimmune folks to have the vaccine?
Yeah, that's a really, really important question, and you could almost answer it yourself because they weren't overrepresented in the trials. Nothing like people who were diabetic or had heart disease or some very common conditions. Some of these immune compromising conditions are much less common, needless to say. So that's my answer. I would never tell a person not to get it, and nobody in the clinical community is doing that. They're all saying essentially, you need it more than anyone else, even though they can't guarantee the result. But I would suspect many of them would have still good results. We're talking about making antibodies against something injected. And that kind of, we call it humoral immunity, could be intact in many of these individuals, not all of them, but still.
Senator Hooker.
Thank you. And thank you, Dr. Levine, for everything that you've done. I want to go back just for a minute to the economy. It's a little off the vaccine discussion, but there are businesses, and we've been hearing from them, who have lead times that they need, significant lead times like months, and they're looking for guidance. Will you have guidance for them within what time period, I guess I'm asking?
Right. You're specifically talking about the 100-person wedding.
The weddings and the marathons and the
concerts, the performances, all of those things.
Yes. So these are all, we have our restart meetings 2 to 3 times a week. And these are all on the agenda of those meetings. And it's just a matter of when we get to that comfort point. Clearly, February, I hate to say it, is still too soon for us to be able to give the announcements that you're looking for, but that doesn't mean March or April won't be. We do know that there's a tightness to that timeline, and it's all of us. It's not just health, it's all of us, dealing with this novel virus and this novel pandemic and trying to figure out when certainty can occur about anything. So stay tuned is all I can say. We're thinking like you're thinking, but we're not ready just yet.
Commissioner, thank you so much for your time, for your hard work, for your dedication, and also I can't think of many states in which the Commissioner of Health would be able to come and speak so clearly and directly to legislators. So I really, really appreciate it, and I know all the senators do. If there are additional questions that you have for the Department of Health, continue to send them along to the Pro Tem's office or to the Chair of Health and Welfare, and we'll make sure we get them over to the Health Department. If senators could stay online, and we will bid farewell to the Commissioner. Thank you so much. We truly appreciate it.
Thank you all. Always a pleasure. Bye-bye.
And we're going to go